Good morning. I am Dr. Rajita Esther. Today I am going to discuss mainly about the skeletal muscle relaxants, that too peripherally acting skeletal muscle relaxants. Okay, last class we have discussed about the MCQs, no? So that we should know clearly about the skeletal muscle relaxants so that we can answer more and give a good answering related to this particular topic MCQs. Why we need a skeletal muscle relaxation? Actually, in conjugation with the general anesthetics, there will be skeletal muscle everywhere in our body. So to insert anything, to cut anything, any muscle over that particular surgical area, we need a optimized environment, a relaxed muscle. So it will be more useful for anesthetic, for facilitating intubation of the trachea during the surgery, facilitate the mechanical ventilation during emergencies in the ICUs, optimized surgical working environment conditions. So it will be very easy for the surgeon to go for the surgeries, to use to cut the muscles because when it is a relaxed state, the skeletal muscle, it will be very much useful. So skeletal muscle relaxants not only useful for the surgeries, addition to the general anesthetic, for the anesthetist, and also to so many people to relax the particular muscle, to introduce anything inside that particular through the skeletal muscle environment. So what is the history of the skeletal muscle relaxants? Actually, did you see this particular image anytime? That the tube, he's holding the tube, and there is at the mouth. From the mouth, he is splitting something through the tube, and that particular thing is going through the tube and going and hitting any kind of an animal or whatever the enemy. Or also they can use some kind of an instrument which are ingested or which are coated, actually coated with this particular skeletal muscle relaxants. So when we are using these particular needles or these particular weapons or the particular arrows to hit enemies or animals, so that that particular animal or the enemy became or becomes skeletal muscle relaxed condition. You might have seen these particular things in so many kinds of the movie. Did you heard it when you have, if you have seen some kind of the movies also, the villains are using these particular um, skeletal muscle relaxants to do so many things against the animals, against the women, and against the enemies. So that the people become skeletal muscle relaxed, so that they cannot do anything that makes that person to do whatever they wanted to do. So curare is a common name for various plant extract. This is also called alkaloid arrow poisoning, originating mainly from Central and South America. Source is Chondrodendron tomentosum and Strychnos toxifera. Tuberculare named because of packing in hollow bamboo tubes. Because that image, this particular tube is the bamboo tube. We are using this particular drug through this particular tube. Uh, that's why we are calling these particular things as a tubocurarine. Let's come to the classification. There are centrally acting, through so many kind of the receptors, mainly GABA mediated receptors and also some of the sympatholytic receptors. So which leads to the decreases the excitation. That decreased excitation by increasing the inhibitory neurotransmitter, which is nothing but the GABA. So we are getting a skeletal muscle relaxation. Let's come to the peripheral acting. They are again drugs acting through the neuromuscular junction. That is the one kind. Another one is drugs directly acting on the skeletal muscles. That is dantrolene. Mainly drugs acting at neuromuscular junction. They are again divided into two types. Mainly two to three. First, mainly one is depolarizing blockers. Depolarizing blockers, that is succinylcholine, decamethonium. Non-depolarizing blockers, all these curare related drugs, pancuronium, doxuronium, piperacuronium, all those things. Others are botulinum toxins, which are acting at the acetylcholine. So these are the drugs acting through the neuromuscular junction. So what is acetylcholine? Acetylcholine is a major neurohumoral transmitter at the NMJ junction, neuromuscular junction. It autonomic, somatic and central nervous system. All preganglionic sites, both parasympathetic and sympathetic, and also at the skeletal muscles and also in the CNS, cortex, basal ganglia, spinal cord and all the other areas, the acetylcholine will act as a neurotransmitter. Parasympathetic stimulation, acetylcholine release at neuroeffector junction, biological effects will be happen when it is released. Sympathetic means when the noradrenaline is released neuroeffector junction, then the biological effects can be seen. So here differences between this parasympathetic system, mainly in the sympathetic system and the parasympathetic system, preganglionically the neurotransmitter was the acetylcholine, which mentioned in a green color. Postganglionic, if the neurotransmitter is acetylcholine, that is the parasympathetic. Postganglionic, if the neurotransmitter is norepinephrine, that is sympathetic. So this is the neuromuscular junction. In the neuromuscular junction with the neuron and the muscle, this particular junction, there are some kind of the these particular cholinergic receptors. Here we will see normally here neuromuscular receptor, that is NM receptor, nicotinic receptors will be there, which through the releasing of the acetylcholine, which acts on those particular concerned receptors and there will be a response. And also this is the ACHE is nothing but acetylcholine esterase, which is an enzyme which will be used for termination by metabolizing the acetylcholine so that it can terminate the effects of the acetylcholine. Okay, let's come to the physiological skeletal muscle contraction. Normally, with the acetylcholine, actually what happens? Motor nerve impulse generation, so releasing of the acetylcholine, binds with the NM nicotinic receptors at the neuromuscular junction. Depolarization and development of the end plate potential at the motor end plate due to the mainly influx of the sodium. So there is muscle action potential contraction of the skeletal muscle. Acetylcholine is rapidly inactivated by the cholinesterase, we know that. And once this particular inactivation is done, repolarization and the muscle again ready for the fresh nerve impulse. So here when we see the action potential generation, when there has to be entry of the sodium. So through the calcium, when it acetylcholine, when it attaches to the NM receptor, there is an entry of the sodium. So there will be action potential generation leads to the contraction of the skeletal muscles. So let's come to these two types of, let's discuss mainly about these two types of the skeletal muscle relaxants. One is the depolarizing, another one is the non-depolarizing skeletal muscle relaxant. In the depolarizing skeletal muscle relaxants, it will mimic the action of the acetylcholine. Already we have seen acetylcholine acting through the NM receptor and causing the entry of the sodium so that there is a contraction. And why when it causing the contraction, why we are discussing it as a skeletal muscle relaxants, under the skeletal muscle relaxant. That is why these drugs are given a name called depolarizing skeletal muscle relaxants. I'll tell you how it is. Another one is a non-depolarizing interface with the action. So it is competitively blocks the NM receptor. So normally NM receptors causes the contraction. Because they are blocking them, there is a no depolarizer, so there will be a relaxation. Depolarizing blockers, succinyl have choline have affinity and submaximal intrinsic activity at the NM receptor. It acts on sodium channels, open them, and causes initial twitching and fasciculation because there is a contraction, entry of the sodium, so there will be a contraction. That's why there is a initial twitchings and fasciculations. It does not dissociate rapidly from the receptors, resulting in prolonged depolarization and inactivation of the sodium channels. That is the main mechanism of action. It's just if it is coming and causing the entry of the sodium, there will be automatically contraction. But it is not stopping. It is continuously making the sodium to enter and continuously causing the contraction. That is nothing but the twitchings and fasciculation. This continuous prolonged depolarization inactivating the sodium channels. That's why there is a depolarization followed by skeletal muscle relaxation. This is the NM receptor. This kind of the receptor is called ligand gated receptor, NM receptor. So this is the acetylcholine actually. When the acetylcholine is attached to this particular thing, alpha unit, so there will be entry of the sodium channel. Okay. Normally agonist opens this so that the entry of the sodium channel. Depolarizing, what it is doing? Depolarizing blockers, what they are doing? They are continuously making it to be happened, entry of the sodium. Non-depolarizing, they are just blocking the sodium channels. So sodium is not entering. Here depolarizing continuously causing the entry of the sodium channel, which causes the desensitization of the sodium channel. So here phase 1, because initially there will be a fasciculation followed by the flaccid paralysis, that is phase 2 repolarization. That's why we are getting a skeletal muscle relaxation. So what are the advantages of the succinyl choline? Most commonly used for tracheal intubation, rapid onset, good intubation conditions, relax the jaw, separated vocal cords and immobility, no diaphragmatic movements, and very short duration. Dose is 1 to 1.5 mg, used as continuous infusion when it required occasionally. Disadvantages are cardiovascular, unpredictable BP, heart rate and arrhythmias, fasciculations, leads to the muscle pain, increased intraocular pressure, increased intracranial pressure, hyperkalemia mainly because of the muscle contraction, all those things. Effects from the muscles, life threatening in the cardiac, heart failures, patients with diuretics and other drugs which are causing with the abnormality of the electrolytes, all leads to the cardiac abnormality. So this is mainly succinyl choline. Non-depolarizing are the competitive blockers. They are again divided into long acting. When they are excreting through the kidney, they are called long acting. Eliminated by the liver, intermediate acting, and inactivated by the plasma cholinesterases which are there in the blood. They are called the short acting. Here they are just blocking this particular NM receptor so that there is no entry of the sodium, so no contractions. They have affinity but no intrinsic activity. They are a quaternary ammonium compounds that contain cationic head that act only on closed sodium channel, no action on already opened sodium channel. The cation head binds to the anion acetylcholine binding site at the alpha subunit. Anytime at the alpha subunit, that will be acetylcholine will be activated at NM receptors, but cannot bring conformational change, and sodium channels will be remains closed. No end plate potential, no muscle action, no potential generation. So muscle action potential will be decreased. Action can be overcome by the because it's a competitive blocker. Whenever there is a competition, one person, if there is other person is the more competitive, they have more energy, more manpower, automatically they will be increased, because this is the competitive blockers. When the NM receptor NM blockers like non-depolarizing blockers concentration is more, the effectiveness will be more. When the acetylcholine concentration is more, so they both compete. Acetylcholine also will compete to occupy that particular receptor. These NM blockers also occupy to compete to occupy. So when, because the acetylcholine concentration becoming more, they are going and occupying, so that NM receptor blocker uh, work strength won't be sufficient to occupy those. That's why action can be overcome by increasing the acetylcholine or blocking the acetylcholine esterase. So channels, acetylcholine is acting and sodium is not entering. Low doses competitive antagonists at the acetylcholine, action reversed by acetylcholine esterase inhibitor or more concentration of the acetylcholine. Large doses, ion channel is blocked, more weakness of the neuromuscular transmission, action could not be reversed by the acetylcholine esterase inhibitor because the dose is large here. So the competition, these particular blockers power is more when compared to this. Other action can block the prejunctional sodium channels and interfere with the mobilization of the acetylcholine even at the nerve endings. So non-depolarizing drugs, first agent is the tubocurane, clinical investigation, purified. So CVS effects, hypotension, mainly histamine will be released, so that skin flushing, frequently autonomic ganglion blockades, because NM receptors, ganglion blockers, both are nicotinic receptors only. NM receptor at the neuromuscular junction, ganglion blockers at the NN receptor. So these also can cause a blockade of this particular ganglion. So that is also a reason for the hypotension. Clinical uses, long duration of action, and CVS effects restricted its use. Used as pre-curization. Pre-curization condition used as. So those are the different types of the drugs. So what are the differences between the tubocurarine and succinylcholine? Tubocurarine is the NM receptor blocker, succinylcholine is the depolarizing. So blockade type, tubocurarine is competitive blocker, succinylcholine depolarizing. Type of relaxation, there is a flaccid paralysis, succinylcholine fasciculations followed by fasciculation because of the first contractions followed by the paralysis. And next, neostigmine addition, which is neostigmine is nothing but the anticholinesterase enzyme which will metabolize the acetylcholine, which can be inhibited by the neostigmine, so that the concentration of the acetylcholine will be more. So when we are giving this particular more acetylcholine, there is an antagonism. Here, acetylcholine, succinylcholine both are the same. So there is an agonism, potentiation of the agonism. Effects of the other neuromuscular blockings, blocking the drug, decreased effect, increases the effect. Histamine release is more in the tubocurarine. Potassium levels won't be have any change, but here because of the continuous contractions there will be efflux of the potassium leads to the hyperkalemia. Pharmacogenetic variations are nil, but when it comes to this, succinylcholine mainly metabolized by the pseudocholinesterase. If the people who are having the deficiency of this pseudocholinesterase, they doesn't metabolize the succinylcholine, so the succinylcholine action cannot be terminated, which leads to the succinylcholine apnea. So we should be very cautious with the genetic variants who doesn't have a or who are deficient of pseudocholinesterase. So those are the main actions of this particular pseudocholinesterase. Directly acting on there will be a ryanodine receptors inside the cells skeletal muscle that are releasing the calcium. That's why there is a contraction. This particular dandrolin will inhibit this particular T type of and ryanodine receptor so that calcium cannot enter inside. So actually we will discuss in the next topic, we will discuss about the uses of this particular skeletal muscle relaxants and also detailed about the succinylcholine apnea. Thank you.